Welcome to EMTprep Pulse Check, the podcast where we help you sharpen your knowledge, ace your exams, and stay field ready. Whether you're prepping for the NREMT or looking to stay sharp in the ever-evolving world of EMS, we've got you covered. Each episode brings educational insights, real-world case reviews, and expert tips to boost your confidence, both in the classroom and on the call. Let's jump in. Today we're going to be discussing CPAP and BiPAP and everything that goes along with it. Afterwards, we'll have some multiple choice questions to review the information we discuss. Let's get started with our lecture on CPAP and BiPAP from Charles, one of our content creators.
Good afternoon, everyone. My name is Charles, and today we're going to be covering CPAP and BiPAP, which is going to fall under airway and ventilation. Just a brief introduction. We're going to be covering over some of the respiratory anatomy and physiology, the difference between an adequate versus an inadequate airway, different types of supplemental oxygen therapy that we use, CPAP and BiPAP introduction, and go a little bit more into depth. We'll go over indications and contraindications of use for CPAP and BiPAP, as well as complications with putting on CPAP and BiPAP, as well as complications of being on CPAP and BiPAP for a prolonged period of time. We'll walk through the procedure of both CPAP and BiPAP and explain some of the differences. We'll also go into respiratory emergencies and talk about some of the different uses we'll end up using CPAP and BiPAP for. We'll talk about assisting patient ventilations with positive pressure ventilation. We'll talk about the use of positive end expiratory pressure, or PEEP. And then we'll go over two different case studies with application of CPAP and BiPAP, and we'll discuss it a little bit more. The respiratory system anatomy. So we know the upper airways consist of the nasal cavity, the pharynx, as well as the larynx or the vocal cords. The lower airway anatomy is going to be the trachea, the left and right main stem bronchi, the bronchioles, and then down into the alveoli. Included in the anatomy is going to be the diaphragm and the intercostal muscles, but this does not fall under the upper or the lower airways. This does help with the process of respiration. Respiratory system physiology. The main function of the respiratory system is going to be gas exchange. We all know the path of blood flow. Oxygen gets taken in while CO2 is taken out. In order for gas exchange to take place, we're going to need three important processes: ventilation, diffusion, as well as perfusion. What is ventilation? Ventilation is the mechanical process of moving air into and out of the lungs. This is going to be composed of inhalation and exhalation. Inhalation, air gets drawn into the lungs by a negative pressure system. So the diaphragm contracts. And you remember, the pressure outside of the lungs in the atmosphere is going to be 760 millimeters of mercury. Inside the lungs at resting, it'll be 760 millimeters of mercury. When we breathe in, the pressure is going to drop in our lungs. Air wants to move from an area of high concentration to an area of low concentration. So when our diaphragm contracts, our lungs expand outward. We draw that air in. We get that oxygen in. Gas exchange starts occurring. And then this is when we move on to exhalation. The air is blown out and the diaphragm and the lungs will return to their normal resting state. And this will be classified as a passive process. So ventilation also depends on two different things: airway resistance as well as lung compliance. Bronchoconstriction versus bronchodilation. So when we're talking about the bronchioles and ventilation, if our bronchioles are nice and dilated, air is very able to move in and out of the lungs without any problems. When we talk about stuff with asthma, COPD, even allergic reactions, bronchioles will become constricted. This makes ventilation incredibly difficult for the patient, and air is not able to really get in or out, and this makes gas exchange extremely difficult. As well as lung compliance. How well does the chest expand to the response to the change in pressure? As we age, our lung compliance will start to decrease due to the loss of elasticity in the lungs. Diffusion. Diffusion is the process by which a gas is moved between the alveoli and the pulmonary capillaries. Changes in the respiratory membrane or increase of the interstitial space will impede diffusion. The endothelial lining of the capillaries must be intact as well for gas exchange to occur. And then perfusion. In order for gas exchange to occur, we have to have adequate blood volume, as well as we have to have adequate hemoglobin. We must also have intact pulmonary capillaries, and the blood needs to be pumping efficiently. Assessment of the respiratory distress patient. So just the view from the door, first thing we're going to look at is how the patient is positioned. How the patient is positioned can tell you a lot about the level of respiratory distress they're in. Are they sitting upright? Are they in the tripod position? Are they up and walking around? How does their skin color look? As the level of respiratory distress increases, depending on what's going on, if they are severely hypoxic, you might end up seeing some cyanosis. They might be completely ashen gray in color, as well as they might be profusely diaphoretic. Mental status. Especially as hypoxia occurs and starts to worsen, the patient will become restless. They might become really agitated or confused. Towards the later stages, they can become really lethargic or somnolent. And then how's their ability to speak? Is the patient speaking in full sentences, or are they only able to speak in 2 to 3 word sentences? And then looking at their respiratory effort. When we walk into the room, do we see any nasal flaring? Are we able to see the presence of intercostal muscles retractions? Are they pursed lip breathing? As well as can we see tracheal tugging? Now this is going to be usually a much later sign in respiratory distress. When these patients use pursed lip breathing, they're essentially creating their own PEEP or positive end expiratory pressure to help recruit some of the alveoli to participate in gas exchange. We'll talk a little bit more about PEEP here shortly. Adequate versus an inadequate airway. An adequate airway is obviously going to be patent with no obstruction, and the patient's able to speak. An inadequate airway can consist of stridor, sonorous respirations, as well as gurgling respirations, or the patient might just be completely apneic. The patient might not even be able to speak, or the airway can be obstructed, whether it's food or a foreign body object. Supplemental oxygen therapy devices. A nasal cannula is usually used in mild hypoxia. This will generally be started off anywhere between 1 to 6 liters per minute, and it will deliver 24 to 40% of FiO2 or fraction of inspired oxygen. Every 1 liter we increase the nasal cannula after that 6 liters, the percentage of FiO2 will go up by 4%. Sometimes you'll see this used in the process of DSI or delayed sequence intubation, when they pre-oxygenate the patient to remove all the nitrogen from their lungs and just put pure oxygen in there. A simple face mask, while this isn't really seen in EMS anymore, you still might see them around. This will deliver anywhere from 35 to 55% of FiO2, and this will be set between 5 to 10 liters per minute. And then a non-rebreather mask, this is technically considered a low flow oxygen and not high flow oxygen. It'll be used at 10 to 15 liters per minute, and it'll deliver anywhere from 80 to 95% of FiO2. We use a non-rebreather for severely hypoxic patients who are ventilating without tremendous difficulty. CPAP. CPAP stands for continuous positive airway pressure. And what CPAP does is CPAP will maintain a constant pressure within the airway throughout the respiratory cycle through a tight-fitting mask. So CPAP will provide that constant pressure going into the upper airways and then even down to the lower airways to help open up the bronchioles as well as the alveoli. CPAP is used for patients in respiratory failure, but they are still able to protect their own airway. And we'll use this for patients with COPD exacerbations, asthma exacerbations, patients with cardiogenic as well as non-cardiogenic pulmonary edema. CPAP was initially used for patients with sleep apnea, but has since made its way into EMS for patients in respiratory distress, more specifically respiratory failure. When used for patients with COPD and asthma, CPAP will actually overpower the residual pressure that will prevent the lungs from emptying on exhalation. Since it's overriding the residual pressure, this will in turn decrease the workload of the patient's breathing, as well as increase their oxygenation. So more often than not, CPAP gets confused with PEEP, or once again, positive end expiratory pressure. But CPAP's a little bit different from PEEP. CPAP provides a continuous pressure throughout the respiratory cycle, both inhalation and exhalation, whereas PEEP will provide that positive end expiratory pressure at the end of expiration, helping keep those lungs inflated. CPAP pressures are going to be measured in centimeters of water, and they'll generally start off with 5 centimeters of water when we place our patient on CPAP. And generally we'll start off with 5 centimeters of water and increase by 2.5 centimeters of water every 5 minutes as needed, based off the patient's presentation as well as vital signs. More often than not, the patient will tell you when they feel like they're getting enough air. BiPAP. BiPAP stands for Bilevel Positive Airway Pressure. BiPAP is described as a continuous positive airway pressure system with a time-cycled or flow cycle change of the applied CPAP level utilizing PEEP. BiPAP utilizes PEEP by utilizing EPAP. The main difference between CPAP and BiPAP is BiPAP you can control several different settings, whereas with CPAP we plug it into oxygen and then we control how much pressure we set it to, once again from 5 centimeters of water to 10 centimeters of water. BiPAP is tremendously different. While CPAP provides one continuous pressure, BiPAP will apply two different pressures known as the IPAP and the EPAP. The IPAP is the inspiratory positive airway pressure, and this will be the pressure at which the patient breathes in. EPAP is expiratory positive airway pressure. This is the pressure that the patient will exhale against. And once again, EPAP is essentially PEEP. They're analogous terms. So BiPAP will allow you to control different settings. IPAP generally starts off with 10 to 15 centimeters of water and will titrate to affect the partial pressure of CO2 in the arterial blood. EPAP will generally start off at 5 to 10 centimeters of water and will titrate to affect our partial pressure of oxygen, or our PaO2, in the arterial blood. We can set a rate for the patient. We can set this, generally we'll set it at 10 to 12 breaths per minute, and this will go more into some of the different settings we use BiPAP for, and we'll go over that here on the next slide or so. And then FiO2, we can actually control the FiO2, or the fraction of inspired oxygen. This can go anywhere from 21 to 100%. For patients in respiratory failure, we're going to start off at 100% of oxygen, and we're going to titrate to the lowest FiO2 possible to maintain an SpO2 of at least 94%. The neat part about BiPAP is that we can actually adjust the tidal volume by increasing the inspiratory positive airway pressure and keeping the expiratory positive airway pressure the same. The ideal tidal volume for an adult is going to be anywhere from 6 to 8 milliliters per kilogram. Other places will tell you 6 to 7 milliliters per kilogram. It's generally going to be in that ballpark though. And it will be of the patient's ideal body weight. You can also control different modes of ventilation. So one of the ones commonly used is going to be spontaneous. This will deliver the IPAP and the EPAP, and it's solely triggered off the patient's respirations. From there's also the spontaneous time mode, and this will deliver the IPAP and EPAP through patient-triggered breathing, as well as the ventilator-triggered breathing. And this will kind of help coach the patient's respiratory rate and to start slowing down their breathing. This one we don't use really that often. This is more for our patients who are going to be intubated and they're on the ventilator. And this will be the machine will trigger all the patient's breath and is essentially ventilating the patient. So CPAP and BiPAP, as well as BVM, all fall under the same category of non-invasive positive pressure ventilation. Some of the benefits of non-invasive positive pressure ventilation is it'll decrease the shunt and opens up collapsed alveoli. In the setting of pulmonary edema, when gas exchange cannot occur, our body will create a shunt, and then since that blood can't go to be oxygenated, the body will shunt that deoxygenated blood back into circulation, and the body will just continuously go without oxygenated blood. It reduces the work of the patient's breathing by improving the atelectasis as well as the VQ ratio. And what the VQ ratio is the ventilation to perfusion ratio. The ideal VQ ratio is going to be 0.8. And when we talk about patients with COPD, pulmonary embolisms, pulmonary edema, the process of a VQ mismatch can occur. And this will happen when part of the lung will receive oxygen without blood flow, or it'll receive blood flow without oxygen. CPAP, BiPAP, as well as BVM are all effective for treating obstructive lung disease. It can also help improve oxygenation as well as hypercapnia. CPAP doesn't do as much for hypercapnia as BiPAP does because you can really control the different settings to help improve the patient's ventilation and how you optimize it. CPAP, once again, is just that constant pressure, so it really won't do much for the hypercapnia portion, but it will do a lot for the oxygenation. It'll also improve alveolar ventilation and gas exchange. In the setting of pulmonary edema, especially, this part is really beneficial. It'll decrease preload and afterload in the heart, which will also in turn decrease cardiac output. This will make it so the lungs aren't going to be filling up with as much fluid, and that positive pressure ventilation will actually start to shift some of the fluid out of the alveoli and into the interstitial space. Non-invasive positive pressure ventilation can also improve lung compliance as well as functional residual capacity. And most importantly, and the main reason why we do this, is it decreases intubation rates and some of the challenges the patients can go through when they end up intubated. Sometimes CPAP and BiPAP will completely reverse it and they will never have to be intubated, especially if used early on in respiratory failure. Indications for CPAP and BiPAP: well, the patient has to be awake and can follow commands. The patient needs to be able to protect their own airway, and the patient needs to be above 12 years old. Generally, anyone under 12 years old will not be able to maintain an adequate mask seal. They also need to exhibit 2 or more of the following emergencies: use of accessory muscles, respiratory rate greater than 22 breaths per minute, and an SpO2 of less than 94%. Contraindications for CPAP and BiPAP: vomiting and upper GI bleed. We don't want the patient to aspirate while they're on CPAP or BiPAP. Respiratory arrest and cardiac arrest. If the patient's not able to ventilate, CPAP and BiPAP aren't going to do much for them. Tracheostomy patients. Putting a mask on a patient with a tracheostomy isn't going to do much of anything. Patients with a suspected pneumothorax, especially more in the setting of CPAP, but due to that constant pressure that's being applied, if there is a pneumothorax, it can cause barotrauma and worsen that pneumothorax till it becomes a tension pneumothorax. And with CPAP and BiPAP decreasing preload and afterload, we also run the risk of hypotension. Always go off your local protocols. Your local protocols will generally tell you what systolic blood pressure to go off of, as long as it's above a certain amount. Most cases it's going to be 100 millimeters of mercury. As long as it's above that, you're generally good to start CPAP or BiPAP. If it's below that, you want to help get that pressure up before you start putting them on CPAP and BiPAP. And then an uncooperative patient. Now this one's more relative, and we'll talk about that a little bit later in the presentation. Complications with applying CPAP and BiPAP: patients with facial hair, dysmorphic facial features, as well as facial trauma can all make it incredibly difficult to obtain a good mask seal. Complications from use of CPAP and BiPAP: with prolonged use of CPAP and BiPAP, you run the risk of local skin damage from the mask seal, possible mild gastric insufflation, especially more in the setting of CPAP with a continuous positive pressure being applied, possible barotrauma, as well as vomiting and aspiration. How to apply CPAP? Well, first things first, as we are taught in school, apply PPE precautions and be scene safe. We're going to assist the patient into a high Fowler's position, and we'll assess vital signs: blood pressure, SpO2, respiratory rate, heart rate, end-tidal CO2 waveform capnography, and EKG if it's in your scope, as well as get a good set of lung sounds. We're going to assess for indications. So once again, is the patient above 12 years old? Are they awake and able to follow commands? Can they protect their own airway? Are they satting below 94%? Do we notice any accessory muscle use? As well as we're going to take into consideration why we're putting on CPAP or BiPAP. Are we thinking it's a COPD exacerbation, acute respiratory distress syndrome or ARDS, asthma, especially status asthmaticus, pneumonia patients, as well as CHF patients? We'll assess for contraindications, so pneumothorax, vomiting, upper GI bleed, hypotension, unable to protect their own airway, tracheostomy patients. We're going to check the equipment, make sure there's no leaks in the hose, make sure we have all of our parts. We'll connect the port to the oxygen main. From there, we're going to let the patient attempt to put the mask on themselves and coach the patient through each step of the process and coach their breathing. We'll start with 5 centimeters of water, and we'll increase by 2.5 centimeters of water as needed based off patient presentation and vital signs. The max we'll go is 10 centimeters of water. We'll secure the mask to the patient's face, making sure to maintain an adequate mask seal and make sure there are no leaks. If you have your end-tidal CO2 waveform capnography cannula on, we can leave it on during the application of CPAP, as this will not affect the mask seal and gives you the ability to consistently monitor waveform capnography. From there, we may administer an inline duonep in conjunction with CPAP as long as it's indicated, and we'll reevaluate frequently for desired effects: SpO2 above 94%, work of breathing improved, lung sounds improved. How to apply BiPAP? We'll apply PPE precautions, and BSI scene safe. We'll place the patient in a high Fowler's position, and once again, we're going to assess for our vital signs, our blood pressure, SpO2, respiratory rate, heart rate, end-tidal CO2 waveform capnography, EKG, as long as they're in your scope, and get a good set of lung sounds. We're going to assess for all of our indications again and consider the main cause of the problem. Are we suspecting COPD, ARDS, asthma, pneumonia, or CHF? We'll assess for contraindications, pneumothorax, vomiting, upper GI bleed, hypotension, inability to protect our own airway, tracheostomy patients, respiratory arrest, cardiac arrest. We're going to check our equipment, make sure there are no leaks in the hose, and we'll connect the tubing to the ventilator. You're going to enter your IPAP and EPAP settings. In most cases, we're going to start off with an IPAP of 10 centimeters of water and an EPAP of 5 centimeters of water. We'll set our desired mode, whether it's spontaneous timed, or it's just timed ventilations. We'll start off with 100% of FiO2, and we'll titrate down to the lowest setting possible to maintain an SpO2 of at least 94%. We'll allow the patient to place the mask on themselves and coach them through the procedure as well as the breathing. We'll secure the mask over the patient's face, and we can leave the end-tidal CO2 cannula on. For hypoxemic respiratory failure, patients not able to oxygenate their blood due to, we'll say, pulmonary edema, we'll increase the IPAP and the EPAP by 2 centimeters of water as needed. So if we start off with 10 centimeters of water IPAP and 5 centimeters of water EPAP, if we need to increase, we'll then set it to 12 centimeters of water IPAP and 7 centimeters of water EPAP. We want to keep the gradient the same between the two, as this will optimize oxygenation and really utilize PEEP. For hypercapnic respiratory failure, we want to widen the gradient between the IPAP and the EPAP. By keeping the EPAP low and increasing the IPAP by 2 centimeters of water, this will allow for optimization of ventilation and allow the patient to really exhale against CO2. Patients with COPD have a really hard time trying to get air out. By keeping that EPAP low, this allows for the patient to exhale at a lower pressure, and this will really allow them to help blow off that CO2. And the best part is we can keep that end-tidal CO2 cannula on, like I said, and this will allow us to consistently monitor waveform capnography. We may also administer an inline duoneb in conjunction with BiPAP if indicated. And once again, we're going to reevaluate frequently for desired effects. An SpO2 above 94%, work of breathing is improved, as well as lung sounds have improved. Respiratory emergencies. Acute respiratory distress syndrome, or ARDS. ARDS is also known as non-cardiogenic pulmonary edema. ARDS is a life-threatening emergency that affects gas exchange in the lungs. ARDS is slightly different than pulmonary edema caused by congestive heart failure, or MI, or even valve disease. When we talk about the setting of cardiogenic pulmonary edema, the left ventricle fails as an effective forward pump, and this causes blood to back up into pulmonary circulation, and this will end up leaking blood plasma into the alveoli, which will then in turn prevent gas exchange from occurring. In ARDS, patients will accumulate fluid due to increased vascular permeability and decreased fluid removal of the lung tissue. In ARDS, the body has a reduced ability to maintain a proper fluid balance. Increases in pulmonary capillary permeability, destruction of the capillary lining, as well as an increase in osmotic forces act to draw fluid into the interstitial space and contribute to interstitial edema. This will increase the thickness of the respiratory membrane and limits the diffusion of oxygen. In advanced cases, the alveoli will accumulate the fluid and collapse the alveolar sacs, and this will prevent gas exchange from occurring. Since gas exchange isn't able to occur, the body creates a shunt, and this will cause a deoxygenated blood to completely bypass it and go back into circulation, resulting in further hypoxia. What can cause ARDS? Multiple different disease processes can cause ARDS, to include sepsis, aspiration, pneumonia, near drownings, high altitude changes, whether it's rapid ascent or descent of high altitude, pancreatitis, opiates, as well as burns or inhalation injuries. Treatment for ARDS. Treatment for ARDS depends on what the underlying cause of ARDS is. Specific management is going to be tailored directly to the specific cause. So this is something we won't really get to treat a whole lot of in the field. So what we can do is early use of CPAP or BiPAP, establish IV access, and give fluids if hypovolemia is present, as well as continuous cardiac monitoring. Cardiogenic pulmonary edema. So once again, this occurs when the left ventricle fails as an effective forward pump, causing pressure to back up into pulmonary circulation, which will lead to the buildup of pulmonary edema. When the pulmonary capillary pressure becomes too high, it will shift the blood plasma into the alveoli, contributing to pulmonary edema. Since gas is unable to diffuse across the alveolar capillary membrane, oxygenation is not achieved. There's multiple causes for cardiogenic pulmonary edema. This will include myocardial infarction, valve disease, more specifically the aortic valve, chronic hypertension, as well as congestive heart failure. Signs and symptoms of cardiogenic pulmonary edema are dependent on what kind of heart failure they have. Usually if someone has left-sided heart failure, they'll also have right-sided heart failure. So things we can look out for are difficulty breathing, tachypnic respirations, tachycardia. They might show left ventricular hypertrophy on their EKG. They can be hypoxic as well as cyanotic. They can have buildup of fluid into the lower extremities, the abdomen, as well as JVD. And the way we're going to treat this is going to be early use of CPAP or BiPAP. We're going to establish an IV and get an EKG, and we'll do nitroglycerin. So if we haven't got the mask on yet, we'll do sublingual nitro, 0.4 milligrams every 5 minutes, as long as there's no contraindications. If we have the mask on, we do not want to break the seal, so we're going to either want to do IV drip nitro or push dose nitroglycerin. IV drip nitro will go anywhere from 5 to 100 micrograms a minute. Every 5 minutes will increase by 5 micrograms a minute as needed. So if we start off with the starting dose of 5 micrograms a minute and we're not getting the effects we want, we'll increase by 5 micrograms a minute. Push dose nitro is very similar to push dose epi. Essentially, you'll take your 10 cc flush, you'll expel 1 cc of normal saline from the flush, and then we'll drop 1 mil or 5 milligrams of nitro from the vial. The resulting concentration will be 0.5 milligrams per milliliter. And our dose will generally be 1 milliliter every 5 minutes. We can also give furosemide, 40 milligrams IV push, if the patient's taking furosemide. And if they're not on furosemide, we'll give them 20 milligrams. Morphine used to be really favorable when it came to cardiogenic pulmonary edema, but over time, as they did more research on it, they realized that morphine is not that beneficial to treating cardiogenic pulmonary edema and can oftentimes make it worse. Obstructive lung disease. Obstructive lung disease covers asthma as well as COPD, which is an umbrella term for chronic bronchitis and emphysema. Roughly about 1 in 12 or 25 million people in the U.S. have asthma. And approximately 16 million Americans have been diagnosed with COPD. Asthma is described as chronic inflammatory disorder of the airways. It'll cause airflow obstruction due to the inflammation, and the patient will not be able to get air in or out, making it difficult for gas exchange. There are several different triggers that will set off an asthma attack, to include smoke, environmental allergens, cold air, exercise, and certain medications. The bronchial smooth muscle constricts and parabronchial capillaries will begin to leak fluid. This will decrease the expiratory airflow, leading to an asthma attack. Asthma signs and symptoms are going to be dyspnea, wheezing or diminished lung sounds, hypoxia, hyperinflation of the chest, pulsus paradoxus, or a drop of 10 millimeters of mercury with inspiration, accessory muscle use, altered mental status, tachycardia, as well as tachypnea. Asthma treatment, so we'll get them on oxygen early. We can do CPAP or BiPAP early on, preferably BiPAP. We'll do end-tidal waveform capnography monitoring. We'll get a duoneb going and put them on the cardiac monitor as well as establish IV access. From there, we'll give 10 milligrams of dexamethasone, either IV, IM, PO, or IO. Or we can do methylprednisone at 125 milligrams IV, IO, or IM. If the patient starts to deteriorate, we can do 0.3 milligrams of IM epinephrine as needed, being cautious with people who are over 40 or they have a history of coronary artery disease, as we're worried for the possibility of an MI. Especially in a long transport time, you can consider the use of a magnesium sulfate drip, and this will be 2 grams and 100 mils over 15 minutes. COPD, once again, it's an umbrella term that covers chronic bronchitis as well as emphysema. Emphysema results from destruction of the alveolar walls, and chronic bronchitis will lead to an increase in goblet cells in the bronchioles, which produces mucin. Gas exchange is decreased due to decrease in alveolar ventilation, which will lead to hypoxia as well as hypercapnia. COPD signs and symptoms are going to be exertional dyspnea. Patient will be speaking in 1 to 2 word sentences, wheezing, bronchi, or diminished lung sounds. They'll have more of a barrel chest appearance. These patients will have a productive cough with sputum, pursed lip breathing with a prolonged expiratory phase, hypoxia, tachypnea, tachycardia, as well as altered mental status. The way we treat COPD is going to be early use of oxygen, CPAP or BiPAP. Once again, preferably BiPAP, as you can control more of the oxygenation versus controlling hypercapnia. And remember, when suspecting respiratory failure secondary to hypercarbia or hypercapnia, and we're using BiPAP, keep the EPAP lower to help offload CO2. We're going to want to put them on the cardiac monitor as well as end-tidal CO2, establish IV access, and give dexamethasone 10 milligrams IV, IO, IM, or PO, or methylprednisone at 125 milligrams IV, IO, or IM. Hypoxic agitation. I use this nifty little chart to talk about the cycle of a COPD exacerbation and how it can lead to hypoxic agitation, making it difficult to help a patient in respiratory failure. So the vicious cycle starts off with dyspnea. The patient feels severely short of breath. Because they feel short of breath and that they can't breathe, they start to become more anxious. The more anxious they get, the more they become tachypnic. The more they become tachypnic, and the combination of obstructed airways leads to an inadequate expiratory time. With the inadequate expiratory time, the lungs will start to hyperinflate. The body is essentially creating its own auto-PEEP, and the gas will accumulate in the patient's chest. When this gas becomes too much, the diaphragm will start to flatten, causing it to work less effectively. Hyperinflation will make it harder for the patient to inhale, and when this happens, the patient becomes more short of breath, and the cycle just repeats itself, and eventually they'll circle the drain until they eventually go into cardiac arrest. So the patient is severely hypoxic. They want nothing to do with any of the oxygen we have. They rip off a non-rebreather. They won't tolerate CPAP or BiPAP. So what should I do if my patient will not tolerate non-invasive positive pressure ventilation? Well, we can always consider the use of sedation. Ketamine is a really good drug that'll help patients, especially with COPD and asthma. Ketamine is very good for it because it causes bronchodilation. Ketamine will also not depress the respiratory drive and is fairly hemodynamically safe. Opioids and benzodiazepines are also used, but they can cause respiratory depression and can have a negative effect on the hemodynamics of the patient. Assisting ventilation with the BVM. The purpose is going to be for patients in the end stage of respiratory failure going into respiratory arrest, where they're not able to protect their own airway. Generally, ventilating with a BVM is going to be a bridge to a more definitive airway can be placed, such as a supraglottic airway like an iGel or a King airway, or until we can get an endotracheal tube placed, or we might have to correct the patient due to an airway obstruction. A BVM can be used, though, if all other airway options have failed. Some of the devices we'll use in conjunction with a BVM are going to be an NPA and an OPA. An NPA is inserted through the nostril and prevents the tongue from falling back and obstructing the airway. However, it is contraindicated in head injuries. An OPA is inserted into the mouth from a 90 or 180 degree angle and rotated into place. Once again, this prevents the tongue from obstructing the airway. This will be contraindicated in patients that have an intact gag reflex. Assisting ventilations with the BVM. So other devices that we use are going to be positive end expiratory pressure valve, or PEEP valve. PEEP valve increases pressure in the airways and allows for the alveoli to remain open even after exhalation. PEEP improves oxygenation by recruiting more alveoli to open and participate in gas exchange. PEEP is able to decrease pulmonary edema by shifting the fluid from the alveoli into the perivascular interstitial space, thereby improving oxygenation as well as ventilation efforts. Indications of assisting ventilations with the BVM are going to be hypercapnic, hypoxic respiratory failure. Once again, this is going to be more of the late stages. Altered mental status with inability to protect airway, as well as apneic patients. Contraindications are going to be total upper airway obstruction. Obviously, you're not going to be able to ventilate. Air won't be able to go down. From there, you're going to have to end up going down criking. Complications of ventilation, dysmorphic facial features, facial hair, as well as facial trauma. So bagging our patient, we want to set them up for optimal ventilation. So apply PPE, BSI, all that fun stuff. We'll assess for indications and contraindications, and then we'll place our patient in a sniffing position or ear to sternal notch. If the patient is morbidly obese, we'll place them in more of a ramping position. We'll consider placing an OPA unless there's a gag reflex present, or 1 to 2 NPAs unless there's a head injury present. We'll connect the BVM to at least 15 liters per minute of oxygen. Ideally, you want to use 2 people. One provider will maintain a mask seal while the other provider ventilates. You have the one-person method where you can do the CE technique, or a different technique, and we'll talk about that here shortly. We'll squeeze the BVM gently over 1 second, delivering an ideal tidal volume, like I said, anywhere from 6 to 7 or 6 to 8 milliliters per kilogram of ideal body weight, which comes out to approximately 500 milliliters. This should be just enough for a chest rise and fall. And we should consider checking for lung sounds as well as utilizing an end tidal CO2 filter line. So we know the classic CE technique for the one-person method. There's another one, which is essentially a jaw thrust and a head tilt chin lift. You take the connector port of the BVM, it goes between your thumb and your index finger. You lower the mask onto the patient using your middle, ring, and little finger to apply under the mandible. From there, you'll thrust the jaw forward into the mask, as well as do a head tilt chin lift. This will get you a great mask seal. And then you have the 2-person method. One provider will maintain the mask seal while the other provider ventilates with the BVM. Rule of 3s for optimal ventilation: 3 providers, 1 provider for the mask, 1 provider for the bag, and 1 provider providing external laryngeal manipulation. Now that's going to be more for intubating, so we don't really have to worry about the laryngeal manipulation. 3 inches, just a quick reminder to place your patient in the sniffing position by elevating the head unless contraindicated. 3 fingers, once again, this is going to be more for intubation, so we won't worry about that too much. 3 airways, worst case scenario, the airway can be maintained with an OPA as well as 2 NPAs. 3 PSI, we want to use the lowest pressure necessary when ventilating, just enough to see visible chest rise and fall. 3 seconds, this is just a reminder to ventilate slowly and allow time for adequate ventilation. And 3 PEEP, or up to 15 to 20 centimeters of water. A positive end expiratory pressure is needed to improve oxygen saturations unless contraindicated. So once again, PEEP is that positive end expiratory pressure that's maintained in the airways at the end of the respiratory cycle that is greater than the pressure of the atmosphere. Remember, the respiratory system is a negative pressure system that draws air into the lungs, and PEEP overrides that. EPAP is essentially PEEP. And CPAP is different than PEEP because CPAP will deliver the continuous positive airway pressure, whereas PEEP just provides positive pressure at the end of exhalation. However, CPAP works fairly similar to it due to providing that pressure the patient has to breathe against. What are the benefits of using PEEP? It will improve oxygenation through alveolar recruitment. It'll increase the airway pressure, as well as increase functional residual capacity, which will decrease the chance of the alveoli and airway collapsing. It'll decrease preload and afterload, which is beneficial for pulmonary edema, as well as increase the partial pressure of O2. Some of the disadvantages for the use of PEEP: your body's not able to eliminate CO2 as well. Overinflation of non-independent alveoli. It can also increase the amount of dead space in the lungs. It can decrease hepatic artery blood flow and portal venous blood flow due to buildup of intrathoracic pressure, and it may increase intracranial pressure due to an increase in intrathoracic pressure. PEEP indications: hypoxia and COPD, CHF and near drowning. It can be used in two methods. The valve, by attaching it to the BVM, can be used both pre and post intubation, as well as just BiPAP. Contraindications are going to be cardiac arrest as well as hypotension, but once again, refer to your local protocols for that systolic number. Due to PEEP diminishing venous return, blood pressure needs to be consistently monitored. Always refer to your local protocols. It can also cause barotrauma. How to use the PEEP valve? So we'll put the patient in our ear to sternal notch position. Consider using an NPA or an OPA. We'll attach the PEEP valve, and we'll start with minimal 5 centimeters of water of PEEP, and we'll increase by 5 centimeters of water until a desired effect is reached, with the max being anywhere from 15 to 20, depending on your local protocols. Asthmatic case study. So you're dispatched to a priority 1 breathing complaint at a local residence. EMS was requested by the daughter after her mom's breathing started to get worse. You arrive on scene. Your view from the door is approximately 40-year-old female sitting in the tripod position in her room. You hear expiratory wheezing from the door. Her skin is ashen gray, and you also note several inhalers on the ground. First thing we need to do is look at the patient and think sick or not sick. And just by the sound of it, this patient sounds really sick. HPI. So her chief complaint is shortness of breath, ongoing for the last 2 hours, worsening with exertion. Her shortness of breath started after doing some household chores. The patient attempted several times to use an inhaler, but all the ones she had were empty, and the patient has no breathing treatments in the house. She reports minor tightness in her chest, but believes it's from difficulty breathing. She also reports she only has a history of asthma, but is otherwise very healthy. Your patient says she's allergic to latex. She takes albuterol inhaler and breathing treatments. Past medical history of asthma. Last oral intake, bagel and a cup of coffee this morning. Events, patient was performing household chores. So our vitals come back as blood pressure 160/92, heart rate of 110, sinus tach on the monitor, respiratory rate of 34, labored but regular, SpO2 of 71% on room air, end-tidal CO2 of 51 millimeters of mercury, with shark fin waveform capnogram presenting, CBG of 132 milligrams per deciliter, and her 12 lead shows sinus tachycardia, no ST segment changes, GCS of 15. We get our full body assessment. Airway is patent, but breathing is tachypnic and labored. Skin is ashen gray, cool, and diaphoretic. Patient is afebrile, non-traumatic as far as injuries to the head, ears, eyes, nose, or throat. Chest, you notice intercostal retractions, otherwise atraumatic with equal chest rise and fall. Abdomen is soft, non-tender in all quadrants and no distension. Extremities, no edema noted, CMS intact, and atraumatic. So we start down our treatment method. Patient is started on DuoNeb and IV is established. You notice the oxygen saturation only increases to 85% and the patient's work of breathing continues to worsen. You delegate your partner to set up CPAP for the patient in the back and will transport code 3 to the nearest appropriate facility. Some things we want to consider. So what settings would we like to start on CPAP with? When we get our patient in the back, our partner's starting to set up CPAP. Maybe we're coming up, or maybe we're setting up epi, IM. Maybe we're just going to put on CPAP and see how we do. But we can all tell from this patient, it seems like she's got a kind of a mixture of hypoxemic as well as hypercapnic respiratory failure. So in this scenario, we started with CPAP, and we want to start with that 5 centimeters of water. And we'll place her on CPAP, and we'll see how she does for a little bit. We'll monitor every 5 minutes. If our sats are going up, we know we're going in the right direction, and we can stay at 5 centimeters of water. If nothing else, we can also go up. We should still continue another inline DuoNeb, and then if we need to do anything beyond that, we'll just be doing single albuterol treatments. Don't forget, we have epi as a backup option to really help open the bronchioles, as well as we can do a mag sulfate drip, and we also want to get some form of a steroid in, such as dexamethasone or methylprednisone. If the patient starts to become really anxious, doesn't want anything to do with CPAP, wants to rip it off, don't forget we can do some chemical sedation with maybe ketamine if we want more of a bronchodilation effect, and if you can get permission from the doc or it's in your local protocols, as well as you can do something small as Versed, maybe even a little bit of fentanyl, sometimes just help and take some of the pain away, can also help relieve the anxiety of CPAP. So a case study on pulmonary edema. You are dispatched to a private residence for an 80-year-old male complaining of shortness of breath, ongoing for the last hour. Patient reported that he went to lie down in bed and he started to feel like he was drowning. View from the door. We arrive on scene. We see an 80-year-old male sitting in the tripod position on the stairs. He's speaking in 2 to 3 word sentences. HPI. Chief complaint of shortness of breath started when he tried to lie down for bed an hour ago. He also reports that he coughed up some pink stuff. He's not sure what he actually coughed up though. Allergies include lisinopril. Patient takes metoprolol, levothyroxine, metformin, nitro, as well as Coumadin. Past medical history of hypertension, hypothyroidism, non-insulin dependent diabetes. Previous MI 4 years ago. Atrial fibrillation, has a history of 1 stroke, and he also says he has a leaky valve. He's not sure what it means, but his cardiologist told him he has a leaky valve. His last oral intake 4 hours prior when he had pot roast for dinner. In events, he was just lying down attempting to go to sleep when his shortness of breath started. So for him, his airway's patent, his breathing is tachypnic and labored, and crackles are heard in all fields. Skin is pale, cool, and diaphoretic with a cap refill greater than 3 seconds. He's afebrile and has no traumatic injuries upon full body inspection. He has equal chest wall movement. His abdomen is non-distended, and no edema is noted throughout any part of the body. For vitals, we get a blood pressure of 200 over 100, a heart rate of 124 beats per minute, and we notice it's irregularly irregular. Respiratory rate of 32, labored but regular. Lung sounds reveal crackles in all fields. SpO2 of 80% on room air. The end tidal waveform shows a normal end tidal with about 45 millimeters of mercury, and CBG comes back at 160 milligrams per deciliter. So we get on scene and we placed our patient on a non-rebreather at 15 liters per minute. We noticed very minimal improvement in SpO2 and no improvement in work or breathing. Now the non-rebreather is more of just kind of bypassing till we get him in the back and we get him on CPAP or BiPAP. From there, we delegate our partner to set up BiPAP in the back. We get an IV established and we administered 1 dose of nitroglycerin sublingual, 0.4 milligrams. So things to consider for this patient. What setting should we start off with on BiPAP for pulmonary edema? Well, one thing we want to do is we want to start him off on that 10 and 5 IPAP and EPAP. We can put him on spontaneous. We can put him on spontaneous and timed and have a mixture of the both and maybe try to coach his breathing. If we need to make any changes to our IPAP and EPAP, maybe his SATs aren't coming up with what we got him on, remember, we'll increase that 10 and 5 by 2 centimeters of water, and we'll keep that gradient the same. Remember, this is more of a hypoxemic respiratory failure. Sounds like he has a new onset of heart failure, possibly due to the leaky valve. So we'll increase as needed. And then should we break the mask seal to administer more nitroglycerin? Probably not. Especially if we're getting his SATs up, we shouldn't break the mask seal just to administer more nitroglycerin. We should go down more of the IV nitro or even push dose nitro. Push dose nitro is very handy if you have it in your system. Always go off your local protocols with what you have. Most places just have sublingual nitro. We'll just consistently monitor this patient throughout transport. We'll get vitals every 5 minutes, and hopefully we start to see a decrease in blood pressure, maybe even a drop in his heart rate or his respiratory rate. All right, guys, that's it.
All right, now let's transition into some multiple choice questions.
Hello and welcome. I'm going to go over a 10-question quiz on CPAP and BiPAP. I'll start by asking the question and presenting the 4 answer options. I'll give you a second to think and decide which answer option or options are correct. Then I'll let you know which one is actually correct, and we'll go over a little answer rationale or explanation on why that is the correct answer. The first question is, CPAP and BiPAP are what forms of ventilation? A is invasive ventilation, B is invasive positive pressure ventilation, C is non-invasive ventilation, and D is non-invasive positive pressure ventilation. The correct answer here would be non-invasive positive pressure ventilation. And it's right in the name if you know what CPAP and BiPAP stand for. CPAP, or continuous positive airway pressure, and BiPAP, or bilevel positive airway pressure, both involve delivering oxygen to the body using a mask and positive pressure ventilation. However, they're considered non-invasive because they don't involve the insertion of a supraglottic or subglottic airway. So it's just delivered via pressure and a mask. All right, let's move on to question number 2. The question here is, which of the following is a contraindication for both CPAP and BiPAP? A, a patient who is in respiratory failure. B, a patient who is above the age of 12. C, a patient with a patent airway. Or D, a patient who is awake and can follow commands. Select the correct answer. The correct answer here would be A, a patient who is in respiratory failure. A patient who's in full respiratory failure cannot maintain their airway or maintain a patent airway on their own. This is a huge contraindication for CPAP and BiPAP, as the patient must be alert and oriented and able to follow directions and protect their own airway. If they're not able to do this, other measures need to be taken. Our next question is, you placed your patient on BiPAP. What should your initial settings be? A, IPAP of 10 centimeters of water and an EPAP of 10 centimeters of water. IPAP of 10 centimeters of water and an EPAP of 5 centimeters of water. An IPAP of 7.5 centimeters of water and an EPAP of 2.5 centimeters of water, or an IPAP of 5 centimeters of water and an EPAP of 2.5 centimeters of water. Select the correct answer. The correct answer here is an IPAP, or inspiratory positive airway pressure, of 10 centimeters of water, and an EPAP, or an expiratory positive airway pressure, of 5 centimeters of water. This is the standard setting when using bilevel positive airway pressure. The next question, or question 4, is the main therapeutic benefit of using CPAP or BiPAP is to do what? A, prevent the patient from going into respiratory arrest by improving oxygenation and ventilation efforts through non-invasive positive pressure ventilation. B, prevent the patient from going into cardiac arrest by improving perfusion. C, prevent the patient from going into respiratory distress by improving oxygenation and ventilation efforts through non-invasive positive pressure ventilation. Or D, prevent the patient from going into respiratory arrest by deteriorating oxygenation and ventilation efforts through non-invasive positive pressure ventilation. This one should be pretty straightforward, but can trip you up due to some of the wording. We, of course, want to improve their ventilation and oxygenation efforts, and we know that this is non-invasive positive pressure ventilation. The key here is that the patient is already in respiratory distress if you're implementing CPAP or BiPAP. So we're not preventing respiratory distress, we're preventing a respiratory arrest, or at least we're trying to. Question 5. You decide to place your patient on CPAP due to hypoxemic respiratory distress secondary to CHF exacerbation. What should your initial PEEP settings be, and how much should you increase it by? A is 2.5 centimeters of water, increasing by 5 centimeters of water as needed. B, 5 centimeters of water, increasing by 2.5 centimeters of water as needed. C, 7.5 centimeters of water, increasing by 2.5 centimeters of water as needed. Or D, 5 centimeters of water, increasing by 7.5 centimeters of water as needed. The correct answer here would be B, 5 centimeters of water and increasing by 2.5 centimeters of water as needed. Standard PEEP settings when using CPAP would be to start at 5 centimeters of water and increase by 2.5 to 5 centimeters of water as needed, depending on how your patient is responding to the implementation of CPAP. Moving on to question number 6. Of the choices listed below, what are the contraindications of CPAP and BiPAP? In this question, there are 3 correct answers. So, A is respiratory arrest, B is cardiac arrest, C is the patient is conscious, alert, and oriented times 4, and D, vomiting. The 3 correct answers here would be A, respiratory arrest. If a patient is in true respiratory arrest, they cannot protect their airway, and so CPAP and BiPAP are not recommended. They also have no respiratory drive, which is a contraindication to CPAP and BiPAP. Cardiac arrest would also be a correct answer. We would not want to use CPAP or BiPAP in cardiac arrest. At that point, we're going to be using a more invasive airway management technique. Again, a patient in cardiac arrest will not have respiratory drive, so this won't be useful. And then D, vomiting. Vomiting is a contraindication because if the patient has emesis in their mouth and then we use positive pressure, they can choke or aspirate on the vomit. Next, question number 7. You arrive on scene for a 32-year-old male with a history of COPD who is complaining of difficulty breathing. Your patient is speaking in 1 to 2 word sentences, and the vitals are as follows: a blood pressure of 149/83, a respiratory rate of 38, SpO2 of 79, and lung sounds reveal wheezing in the upper lobes and diminished breath sounds in the lower lobes. What is the most appropriate treatment to provide for this patient? A is CPAP at 20 centimeters of water with inline albuterol treatment. B is BiPAP with an inspiratory positive airway pressure of 10 centimeters of water and an expiratory positive airway pressure of 5 centimeters of water with inline albuterol treatment and IV therapy. C is a non-rebreather at 15 liters per minute with inline albuterol therapy and IV therapy. Or D, a nasal cannula with nebulized albuterol treatment. The correct answer here would be B, BiPAP with an IPAP of 10 and an EPAP of 5 with inline albuterol treatment and IV therapy. This patient is in significant respiratory distress and is most likely going to rapidly decompensate without aggressive management. So initiating BiPAP to help with gas exchange and ventilation, initiating albuterol to open those constricted lower airways, and establishing an IV would be the best treatment of the provided options. Question number 8 is, which is the correct treatment for a 65-year-old female experiencing pulmonary edema? A is a nasal cannula at 2 liters per minute and nitroglycerin. B is a non-rebreather at 15 liters per minute with nitroglycerin and morphine sulfate. C is a CPAP or BiPAP, nitroglycerin and lisinopril. Or D, CPAP or BiPAP with nitroglycerin and furosemide. If your patient is experiencing pulmonary edema and is most likely in respiratory distress, CPAP or BiPAP would be a good place to start, especially if used in conjunction with nitro and furosemide. CPAP and BiPAP are going to provide that non-invasive positive pressure ventilation that'll help reduce preload, afterload, and venous return. So that'll help reduce the amount of pulmonary edema in the lungs. It's also going to help shift fluid out of the alveoli. Nitroglycerin is also going to help reduce preload and help shift fluid out of the lungs. Furosemide is going to help excrete that excess fluid in the urine. Studies have shown that morphine is falling out of favor, so that's not going to be beneficial, and lisinopril is used to treat hypertension. So non-invasive positive pressure ventilation and then some treatment to help open the airway and excrete fluid is going to be the best treatment here. Question number 9. Why is BiPAP preferred over CPAP in asthma and COPD patients? A, BiPAP allows the patient to exhale against a lower pressure, helping improve ventilation efforts. B, BiPAP is preferred because it maintains continuous positive airway pressure. C, BiPAP is not preferred and should not be used in these patients. D, BiPAP allows for the use of duoneb in conjunction with BiPAP. So BiPAP, or Bilevel Positive Airway Pressure, provides 2 pressures, as we've previously discussed, an inspiratory pressure and an expiratory pressure. Because asthma and COPD are considered air-trapping conditions, having a lower pressure against which the patient has to exhale, so that EPAP, can help improve ventilation and gas exchange, which is why it's the preferred method over CPAP in asthma and COPD patients. All right, time for our final question. Question number 10. What is one of the major benefits of early CPAP and BiPAP use in respiratory distress patients? A. There is no benefit of early intervention. B. It can prevent the patient from having to be intubated and on a ventilator. C. It resolves all signs of respiratory distress. Or D. It can prevent the patient from becoming septic. The early introduction of CPAP and BiPAP are definitely beneficial for a patient in respiratory distress. The primary reason for this is it can address a lot of the symptoms and help to treat the underlying condition that's causing the respiratory distress, which would prevent a patient from having to be intubated and placed on a ventilator. Thanks for joining us for this quiz on CPAP and BiPAP. Hope to see you next time.
Thanks for tuning in to EMTprep Pulse Check. If you found today's episode helpful, be sure to subscribe, leave a review, and share it with your classmates and crew. For more test prep tools, study guides, and practice exams, head over to EMTprep.com. Until next time, stay sharp, stay safe, and stay on pulse.